talk. Next, we move on to the next talk about cranial nerve palsies by Dr. Rehna. She is an assistant professor in Department of Ophthalmology, Amrita Institute of Medical Sciences. Over to you, Dr. Rehna.
Good afternoon. First of all, let me thank Dr. Kalaimati for giving me this opportunity to present in this instruction course. The topic is cranial nerve palsies. In this presentation, I'll be dealing mainly with third, fourth, and sixth cranial nerve, which innervate the extraocular muscles of the eye. The course of the cranial nerves can be divided into nuclear, fascicular, basilar, intracavernous, and intraorbital. First of all, let's go through anatomy a little bit. The oculomotor nerve nucleus is situated at the midbrain at the level of the superior colliculus. There are two nuclei, the main motor nuclei and the Edinger-Westphal nuclei, and it's related to other important structures such as red nucleus. And it is composed of an unpaired levator palpebral superioris nucleus, which is innervating bilateral levator. So any lesion causes bilateral ptosis. Then there is a paired superior rectus nucleus, which is innervating the contralateral superior rectus. Then the paired inferior rectus, inferior oblique, and medial rectus subnuclei, which is innervating the ipsilateral side, and an impaired Edinger-Westphal, which is innervating both the pupils. The main lesions are vascular infarctions, primary and secondary metastasis. Oculomotor nerve is entirely motor, and it supplies all the extraocular muscles and the levator except the lateral rectus and superior oblique. So fascicular lesions, it depends upon the site of involvement and another structure which is affected. So I'll rush through this. There are different syndromes depending upon the other, like if the red nucleus is involved, it's called Benedict syndrome with associated contralateral extrapyramidal signs. In Weber, the cerebral peduncle would be involved, causing contralateral hemiparesis. North-Nangle, superior cerebellar peduncle, and Claude is a combination of Benedict and North-Nangle syndrome. So basilar course is when the nerve exits the brainstem and is coming out before piercing the cavernous sinus. Here, it passes between the posterior cerebral artery and the superior cerebellar and parallel to the posterior communicating artery. At this point, the nerve is actually traveling alone, and so the isolated lesions can occur in this region. Having said that, the trochlear nerve and abducens nerve also go through the same path, except that they are inferiorly lowered down. So what is pupil sparing third cranial nerve palsy? At the basilar portion and at the cavernous portion, the pupilomotor fibers are actually superficial in the nerve, and it's supplied by a pile plexus. But inside, or the main trunk is supplied by the vasonervosum, so if there is an ischemia, the main trunk is affected, sparing the pupillary motor fibers, and thus causes a pupil sparing third cranial nerve palsy. And after the basilar portion, it goes into the cavernous sinus, where the nerve fibers are arranged like that, oculomotor, then comes the trochlea, the first and the second divisions of the trigeminal, and the abducens nerve at the center, along with the internal carotid artery. So here, any lesion causes multiple cranial nerve palsy at the cavernous sinus. And different lesions which occur here are pituitary apoplexy, diabetes, aneurysms, or meningioma. So after exiting the cavernous sinus, it goes through the orbital apex into the orbit. It goes through the superior orbital fissure, which is actually a cleft which is formed between the greater and the lesser wings of the sphenoid. And the nerves are clustered here with in the annulus of Singh, we have the superior and the inferior divisions of the oculomotor and abducens nerve. Here we have LFT, lacrimal, frontal, and trochlear. And once in the orbital, once inside the orbit, it supplies the corresponding muscles. So the presentation, the eye would be turned out and down. There will be complete ptosis if it is complete involvement, and there will be limitation of elevation, adduction, and depression, and the pupils will be dilated, and there will be absence of both direct and consensual. Going to the trochlear nerve nucleus, it's located in the midbrain, but it's at the inferior colliculus, and it is the only nerve that exits through the dorsal portion of the midbrain, and it's the longest and the slender nerve. The causes, it's mainly idiopathic, which is congenital. Other causes are trauma, microvascular conditions, aneurysms, and tumors. Clinically, if it is congenital, the patient may be asymptomatic, except that there would be a head tilt. And the diplopia, if it is acute, it will be vertical. There will be limitation of depression. So this nerve is tested in depression in adduction. So if there is a third nerve involvement as well, then we have to do the same and look for whether the eye is indoting. Okay, and bilateral involvement, there will be right hypertrophy on the left gaze and left hypertrophy on the right gaze. Let's look at the Park 3-step test. Here in the primary position, the eye is hyper. When the patient is moving to the opposite side, hypertrophy is increasing. And on head tilt, it increases to the ipsilateral side. That's why in superior oblique palsy, the patient tend to adopt a head tilt to the opposite side to relieve the diplopia. The sixth cranial nerve nucleus, it's located at the pons. And it's also related to important structures like facial nucleus, facial colliculus, medial longitudinal fasciculus, and the cerebral corticospinal tract. So depending upon the site of involvement, there will be associated features like facial nerve palsy or the fifth nerve involvement. And once it comes out of the brainstem, at the CP angle, it's closely related to 7th, 8th, 5th cranial nerve, and it goes up and reaches a petrous temporal bone where it's related to trigeminal and then pierces the dura into the cavernous sinus into the orbit. The causes of 6th cranial nerve palsy could be ischemic. Any case of 6th nerve palsy, you have to do a complete neurological examination. In case of tumors, if it is CP angle tumors, look for the 7th nerve, 5th corneal sensation, and also the hearing. Another cause is trauma. Then we all know elevated ICT. So dilate the pupil and look for papilledema. And infections like medullary infections and meningitis causes like medullary infections called Grady-Negro syndrome, facial pain, and 6th nerve involvement. So that is the presentation. The patient will present with diplopia and it's uncrossed diplopia. The primary position eyes will be ESO and there is limitation of abduction and the face will be turned to the ipsilateral side. So whenever you see multiple cranial nerve palsy, it's not benign microvascular. Should think about something else. As I said, in superior oblique fissure, the multiple cranial nerves are there. So simultaneous involvement of 3, 4, 6 and the 5th cranial nerve locate the lesion to the cavernous sinus. So if it is bilateral involvement of the cranial nerves, it suggests a diffuse processes like infiltrative lesions, malignancies, leukemias, or a midline lesion that extends bilaterally like nasopharyngeal carcinoma or a meningeal process. In superior orbital fissure, we already said it will be multiple cranial nerves. And if the lesion is at the orbital apex, optic nerve will also be involved and the patient presents with decreased vision with multiple cranial nerve palsies. So this is one of our patients who presented with decreased vision and he had proptosis on the left side, complete ptosis and limitation of movements in all cases and absence of consensual on the other side. So differential diagnosis in such cases, of course, orbital apex, cavernous sinus, especially if the patient is systemically unwell. SOF syndrome, in fungal infection should be suspected like mucor. If the patient is severely debilitated or has uncontrolled diabetes. Tolosa-Hunt syndrome is an inflammatory process involving the superior orbital fissure and the cavernous sinus. So how do we manage? These patients should undergo MRI brain CT angiography, especially if it's a pupil involving third nerve, a painful ophthalmoplegia, worsening cranial nerve palsy, partial or not improving. If it is a pupil sparing or if it is fourth nerve or sixth nerve, you want to observe if it is not improving beyond 6 weeks and younger age of the patient. An MRI orbit should be included if you are suspecting orbital apex or superior orbital fissure. And if you are planning to observe and thinking about vascular causes, rule out diabetes, hypertension, a lipid profile, ECG, BP should be done. Treat the underlying cause. If ischemic, usually resolves in less than 3 months. In between, you can occlude the eye or prisms can be used to avoid troublesome diplopia. Surgery for the ptosis or strabismus should be considered only after 6 months and the ptosis is, or the deviation is stable. Thank you.